one thing I have to say that I think is just wonderful is it doesn't matter how old you are. Our parents always want to come and see what we're doing, and they're always so proud of us. So his mom and dad are here to watch him today, too, which I love. I love, I love, I love. So with that, I'm going to go ahead and hand it over to Dr. Freeman, and we'll get started.
Thank you, Corey. Thank you for coming out today. I'm excited to be here, and I'm glad we got a lot of people here. And hopefully this will be a beneficial talk, and you'll gain some information that will help you or a loved one with their foot or ankle problems. I was actually raised in this area, so just a little bit about me. My mom and dad are farmers, and I grew up in Basin City, and I was raised on a farm. And I remember at a young age, you know, as a farmer, you tend to not go to the doctor unless absolutely necessary. And I remember coming to my dad and my big toe, and we were just talking about this the other day, actually. My big toe was red and swollen, and I had an ingrown toenail, and I said, "Dad, what do I do with this?" And so he sat me up on the bed and went to work on me and showed me how to fix it myself. I won't tell you how we did it because it's probably not the best way to treat an ingrown toenail, but we'll talk about that. So why come see a foot doctor? The foot has nearly a quarter of the bones of the human body in just the 2 feet alone. There's 26 bones in each foot, 56 ligaments, 38 muscles that act on the foot, and many nerves and blood vessels. These are a couple of the slides that we had to learn in residency in medical school, and there'll be a test afterwards. But it's a pretty complex structure. So when somebody comes to me and says, "Oh, my foot hurts, doctor," and where does it hurt? Because there's a lot of structures in the foot. I mean, it's pretty small relative to the rest of our body, but it's very complex. As a foot and ankle surgeon, I treat nearly all aspects of the foot and the ankle. Things related to the bones, fractures, sports medicine type injuries for athletes, surgical treatment, as well as biomechanic treatment such as orthotics, bracing, things like that as well. And I treat patients from 1 to 101. So this is just a little bit about my training. I think the highlight of my training as a doctor was my time spent at the Cleveland Clinic. It was a world-class hospital with great facilities and great mentors that taught me a lot, and I really felt like it was state-of-the-art in the technology and the approaches to what we did. As a podiatrist, we do go through surgical certifications. You know, if you're going to go see a podiatrist, you know, I don't expect you all to come and see me, but make sure they have surgical certification in foot and ankle surgery. That really sets them apart as some advanced training and education. So don't wear those. So that's not what you should be wearing. The typical population that I see in my office is anybody. So 50 to 75% of patients will need care for their feet by a physician. I remember I had plantar warts as a child, so I went and got my feet treated by a physician as well. So a lot of people have foot problems during their lives. Part of it's people are living longer than they used to, where people are heavier than they used to be. And that puts more pressure on the feet. And then we are more proactive about treating ourselves too. Like we talked about the farmers not getting treatment. Well, people are going to doctors more often than they used to in the past. Women are about 4 times as likely as guys to come and see a foot doctor. And I've thought about that, and why do you think that is? Well, this probably has something to do with it. But there's other reasons as well. Women care more about what their feet look like, so I see women for cosmetic things as well. They are fitting in tighter shoes. Even if you're not wearing high heels, tighter shoes can lead to foot problems, whether they're flats or dress shoes, and sometimes even an athletic shoe to make your foot look smaller. So they are more common. The other thing is women go through childbirth. And while they are carrying a baby, they have this hormone in their body called relaxin. It actually relaxes all the ligaments in the human body. It's made so that the baby can pass through the birth canal, but it actually can affect the foot, and the foot can flatten a little bit during pregnancy, and it can stay that way for the rest of the life and lead to some foot problems. And I think that's another reason why. So what's the big deal? We spend a lot of time on our feet. The average person takes about 7,000 steps, and we put 1.5 to 2 times our body weight on our foot each time we step. So if you think about that, that's a lot of weight. If you're running, it's up to 6 times your body weight that goes through your foot every time you strike the floor. So the moral of the story is you better take care of your feet. They need to carry you for a long ways. If you don't get anything else out of this talk, besides this slide, this is probably the most important thing to avoid foot problems. Really taking care of your feet, making sure your skin is well cared for, but the shoes you wear are very important. You want to make sure that you're replacing your shoes fairly frequently. The recommended mileage is about 500 miles. It's kind of hard to judge, but it's about every year for everybody, unless you're a runner or a jogger or an avid walker. Whereas you may need to replace your shoes every 3 or 6 months. And then depending on weight, if you're heavier, you're gonna put more stress and strain on your shoes as well, and they'll need to be replaced more frequently. So if your shoes look like this, that's kind of a small picture. But if it was once flat and it's now rounded on the bottom when you set it on a flat surface, it's time to get new shoes. If you can see your toes, it's probably time to get new shoes as well. This is a little more subtle problem. You see how these shoes are kind of angled in? So that's a bad sign, or angled out. If you set it on a flat surface and your shoe is angled to one side or the other, it's time to get that shoe replaced because you've either compressed the foam or you've worn off the sole to where that shoe is no longer supportive. So here's a shoe that's in a high heel, and this is why a high heel is bad. One, the Achilles tendon is tighter than it usually is, and also you're forcing basically a lot of your body weight on the ball of your foot where it's not designed to be. These are a picture of some dress shoes that are orthopedic type dress shoes. You see how the toe box is actually wide, like our foot, instead of pointed, like, I don't know who came up with the design of a pointed shoe, but anyways. But our foot is more shaped like that. So there are cute shoes out there for ladies that are more orthopedic-like. This is a great type of tennis shoe, and actually you'll find that you get what you pay for. So it's going to cost some money to get a good pair of shoes. Don't expect to pay anything over about $150, but if you're spending between $60 and $150 is almost a necessity if you're going to get something that lasts and that is actually supportive. The materials are better, it'll last longer, and it'll support your foot and hopefully keep you away from foot problems. And make sure there's room in the toe box. We'll talk about the reasons why for that. You want your 2 toes to be able to move up and down, and you want them to be able to move side to side slightly. Any questions about what we've talked about so far?
What do you think about the styles today? I think they're terrible.
That's a good question. The styles today, a lot of there's a lot more flats, there are high heels, and there are a lot of flip-flops.
Flip-flops, that's what I mean.
Yeah, there's a lot of people wearing flip-flops, and it's like wearing nothing. It may be worse than wearing nothing because you grip that flip-flop every time you take a step, which I think leads to hammer toes, which we'll talk about. So flip-flops are not a good option. There are sandals that are orthopedic sandals now as well. They have arch supports. They have a footbed. Birkenstocks are a better sandal if you're going to be wearing a sandal. Probably not the ideal footwear, but I wear sandals too. But I do wear orthopedic sandals. I don't wear flip-flops. So these are some of the conditions we're going to go through today. We're going to start with the one that brings me the most new patients, and actually any podiatrist new patient visits. This is the most common problem that they come in for. Plantar fasciitis. Anybody here had heel pain in the past? Okay, and who's been diagnosed with plantar fasciitis in the past? So common condition. That's a lot of people in an audience. So this is the most common complaint. Why does my heel hurt so bad when I first step out of bed in the morning? Or for those of you that have prostate issues, every time you get up in the middle of the night, it hurts like crazy for a few steps, and you don't have time to work it out in the middle of the night. So it gets better when the more you're on it, and then it gets worse again throughout the day. Plantar fasciitis is basically an inflamed ligament. You can see that little spur of bone. That spur doesn't need to be removed, but it's a sign that that ligament has had chronic stress on it, leading to what we call plantar fasciitis. So treatment for this. When a patient comes in, I tell them it's basically two main things in one that's going to help things feel better. The first thing is stretching. The second is good support for your feet. That includes a good supportive shoe, but also an arch support typically in that shoe. That arch support supports that ligament that's on the bottom of your foot and makes it less stressed right at the back of the heel where it hurts. There are lots of other things as well, rest, ice, injections, physical therapy that'll also help, but it's stretching and support. We won't go into the details, but if you have this problem, you can go online and you can start the stretching, you can start the support with the appropriate orthotics. And surgical, basically we cut the ligament and it releases some of the tension. It's an important ligament, we try not to do it, and 95% of people get better without surgery for this problem. Achilles tendonitis, so this is a bump in the back of the heel is typically how this presents. And it hurts, especially if you're going up and down heels. Most of the time this will present after somebody has been, started a hiking regimen, or going up Badger Mountain is a great place to hike, but I see a lot of patients that come in after going up and down Badger Mountain because of the incline. It puts a lot of strain on the Achilles tendon in the back because your foot is constantly pointed up, going up an incline. A great way to exercise. I'm not trying to discourage you from doing that, but it can sometimes exacerbate an already predisposed or a patient that already has some mild inflammation. Sometimes there will be a spur in the back of the heel. This is a lady that came in and she had a big spur in the back, and if she wasn't getting better with conservative treatment, so we shaved down the heel. You have to almost detach the Achilles tendon, and so then you anchor it back down with actually a couple of screws that have some polyester ties, and you tie that back down. Patients do very well, and most patients are very satisfied after surgery. Wearing high heels. So again, don't wear your high heels, at least if you're going to wear high heels or a shoe with a heel, short periods of time. An hour a day, or not an hour a day, but special events. I don't recommend them, but if you're going to do it, make sure it's for short spurts. If you are working and you're on your feet a lot, high heels are not what you should be in. You need to be in a good shoe. Treatments. Basically, we rest that tendon, get it calmed down, and then we start the stretching process. It's often due to a tight Achilles tendon, so we need to get it stretched out. But if you stretch it too much when it hurts, it can make the problem worse because it's an overuse problem or injury. Flat feet. Who's been told they have flat feet before? So another common thing. They used to not let you go into the military if you had flat feet. That's kind of been debunked, although sometimes if it's bad enough, it can cause enough pain that they still don't let you serve in the military. So why don't I have an arch? Sometimes we're born with it. If it's not causing pain, it's really something that doesn't have to be treated. But if it is causing pain, you need to see a physician. And if you're older and you didn't have a flat foot or a really flat foot and it's worsening, you need to see a physician. So the adult acquired flat foot is what we call that. It's basically just chronic overuse of one of the main tendons in the foot, but it can lead to a lot of problems and a lot of pain. But it's treatable if you catch it early. So if you feel like your arches are collapsing or you have pain along the instep of the foot or along the middle of the foot or the inside of the ankle, that is something that needs to be seen. So the initial treatment for both a congenital, so a kid that's born with it, or an adult that starts to have a flat foot, is arch supports. That's the first thing. These are a picture of the arch supports that I often recommend. These are multi-density insert. You may have seen some of the hard plastic ones. I use those too, but they're not as forgiving. In my older patients, these tend to work a lot better. If arch supports aren't enough, then we go on to something like this is a short articulated ankle brace that I often use. The nice thing about this is it can stay in the shoe, and you can slide your foot into the shoe from behind. Nobody likes to wear a brace, but if it helps your pain, I have patients that are walking around in these every day, and they offer a lot of relief for an adult-acquired flat foot. Surgical treatment, again, last option. It's a pretty major reconstruction. This is a kid, actually, that had a pediatric flat foot and had a congenital deformity of this joint. So we had to break the joint, reset it into a new position, and then we actually lengthened a couple of bones to put his foot into a better position. So bunions, another common one that a lot of people will see. What is a bunion? So a lot of people, when they say, I have a bunion, they think I have a growth of bone next to my big toe. It's not a growth of bone, typically. Once in a while we'll see that, but it's actually a malposition of the bones. So if you look at this x-ray, the metatarsals, these are these long bones right here, they should be nearly parallel to each other, or at least close to each other like these two. In a bunion, the first metatarsal angles away from the second, and then the big toe, because it doesn't like to stick out here straight by itself. Can you imagine getting a shoe on if your toe was sticking out like that? The big toe goes to the side. And that's what makes this bone really prominent out the side. So this is kind of a moderate bunion. Again, it's the angle between those two bones, and that bone sticking out. And here's a more severe bunion. I call the big toe the bully of the foot because he's bigger than all the other kids on the block, the smaller toes, and he pushes his way around. So either the toes are going to follow him and they're going to go to the side, or they're going to move out of the way. And this, you see these ones, they said, we're going to go where you go, big toe. And this one said, no way, and he hops on top of the big toe. Well, this is a very painful condition. It's hard to get into a shoe when you have a second toe on top of a big toe. I have had patients that will do cutouts on the top of their shoe, and you can do shoe stretching, and sometimes it'll be enough, but sometimes it won't be. And then surgical treatment can address that. So we talked about, my mentor, Dr. Grossman, a renowned foot and ankle surgeon in Akron, Ohio, he told me, or he would tell his patients, you either accommodate it or you fix it. So that basically boils down bunions. So you either make room for it in your shoes, you can try padding, but it sometimes increases the girth. You either make room for it in your shoes or you get them fixed if they're causing you that much of an issue. There's two main ways that we treat bunions. There's more than just these two ways, but you can either cut the bone here and shift over this part of the joint, and then you fix it in a different position. And this is they call this a headless screw. So one thing nice about the technology nowadays is bunion surgery. A lot of people were non-weight bearing for a long time. Basically all the bunion surgery I do now, patients can walk the day of. It hurts, and so they're going to be off it for a little while. But you can walk the same day because the technology is better than it used to be. We used to use just a metal wire or rod to fixate the bone cut. But now we have these neat screws, and these screws, they never need to be removed because they're all inside the bone. So here is that big bunion that we saw before, and when it's this large, I mean, you can imagine you shift this head over and she's still got a bunion. And so you have to come back at where the deformity is starting, back here. And you have to fuse this joint. And that joint doesn't move much, so patients don't miss that joint. I actually do this surgery in kids as well as adults. Some kids have a very flexible a flexible bunion. And in that case, if you do the procedure out here, that bunion will come back. And so we treat it back here. And again, it looks like a lot of metal. This rarely has to come out because it's in a place where it just doesn't seem to rub against shoes. And then patients can weight bear right away. This used to be 6 to 8 weeks non-weight bearing. But thanks to newer technology, and there's that screw again. It's a headless screw. It's all inside the bone. Never needs to come out, which is really nice. Makes recovery from these surgeries a lot better. Hammer toes. So we talked a little bit about the hammer toes. That second toe being on top of the big toe is also considered a hammer toe. So the second toe up in the air, you see the callus on top of it. And there's another picture of it. So treatment for hammer toes, similar to a bunion, honestly. You know, that callus on top is a sign of underlying problems. Just treating the callus is going to be putting a Band-Aid on it, and it's going to keep giving you problems. You either make room for it in your shoes, where you can, there's actually, hammer toes are, they do a little bit better with shoe gear modifications than bunions. You can actually do spot stretching. There's some shoe stores in town. There's Uptown Shoe Repair and A1 Shoes in Kennewick. They will stretch shoes, and you can actually spot stretch a shoe, especially if it's a leather shoe, and make room for some things. Still may not be enough, but it's something worth trying. And then there are lots of cool pads and things that you can put on top of a toe. Don't use callus removers, though. I've just seen patients that have come in with sores and wounds that are difficult to heal. You know, without knowing if you have really good blood supply to your feet or if you have diabetes, you know, you really want to stay away from these acid or medicated corn removers. Padding around them is fine. You can do any padding you want to try. Just make sure you're keeping a close eye on your foot, because any new padding can cause a blister or a problem. So make sure you monitor your foot frequently if you start something new. Surgical treatment for hammer toes, again, this is how we used to do it, and some people still do. Little wires sticking out the end of the toes. Well, the problem with that is they get caught on things sometimes, and you can't shower for 4 to 6 weeks with that. A lot of the newer technology is these little implants that go in the joint. To fix a hammer toe, typically it requires breaking and straightening out the toe, and we actually remove that little joint. Makes the toe a little stiff, but it straightens it, and patients have good outcomes from it. My mom actually had a procedure. My partner did it because they won't let me operate on my own mom, which I was grateful for. It would have been a little... but she had a procedure like this, and she's very happy with her second toe that was sticking up, was rubbing on shoes, and had a callus. I hope she doesn't mind me sharing some of her medical stuff. And this patient, we call this basically a 4-foot reconstruction. The big toe was pushing everybody else out of the way, so we had to straighten out the toes as well as the bunion to give her some relief. And this lady was she was on her feet a lot, custodial type work, and she is able to go back to work and was very happy. Arthritis in the foot and the ankle. This includes a lot of things. We're going to talk about 3 main areas where we get arthritis in the foot and the ankle. We're going to talk about the ankle joint. So this is a picture of arthritis in the ankle joint. You can see there's some space between these 2 bones. You're supposed to have that space there. That's because you have this material in between your bones called cartilage. It's kind of rubbery. And then we have this fluid, that's the grease, that allows those joints to glide. Once the joint becomes damaged, it becomes rough and it starts to wear down over time. And this becomes bone-on-bone arthritis. Knees, we replace. And we can replace an ankle joint, but the gold standard still is actually fusing an ankle joint. If the arthritis is so bad, again, you know, surgery is not for the faint of heart, and it's not for people that aren't having a lot of pain. But if it's really painful and it's not getting better with the other treatment, a fusion, actually locking up the ankle joint. Well, you say, wow, my ankle joint won't bend anymore. They've done lots of studies. People that have a fusion are just as happy as those with a replacement. The problem with the replacement is you're much more likely to have future surgeries and revisions and problems with it. But we still do replacements. It's a good option. And it's actually better in older people than younger people, a replacement. But conservative treatment for an ankle is basically trying to limit how much motion goes across that joint. That's via bracing. So this is a solid ankle brace. This is a rocker soled shoe. Skechers makes these shape-up shoes that are supposed to tone your bottom and your calves. I don't know if they really do that, but they're a great option for ankle arthritis or midfoot arthritis because it doesn't require as much movement of the foot joints. So that's an option, and then locking up the ankle joint with a brace. but those braces can be cumbersome, and you can still have pain because the ankle is still a weight-bearing joint. So even though you may not be moving that joint, you can still have pain just from the pressure going down to the body. Big toe arthritis. So you can see here's another one with basically no joint space left. It's a bony lump. The first thing that I try is getting a stiff-soled shoe. And that's the same actually for midfoot arthritis or arthritis in the middle of the foot. Those rocker-soled shoes or a shoe that doesn't bend real easily. And the nice thing about that is it basically takes away some of the motion that's usually required to walk. That shoe will take up some of the motion and keep that joint from moving as much. If that doesn't work, we can clean up the joint, or we can fuse the big toe joint if it's arthritic. So we don't take it out. So if the toe is painful through the whole range of motion, nothing we do is going to fix that joint unless we replace it or remove the joint and make it one solid bone, so that painful motion is now gone. So a lot of people are like, well, can I still walk normally if I have my big toe joint fused? Most people with arthritis in their big toe joint, that toe isn't moving anyways, and the little movement that it does have is painful. And so you remove that joint. This is a great surgery because patients get nearly 100% relief of their pain, even though you're... They can. So we take the joint out and we actually make it so that it becomes one solid bone, and they can still move around just fine. There are marathon runners that have a big toe joint fused, and you can still walk completely normally with it and do most of everything still. Bending down, you have to change how you bend down a little bit. So if you're on your knees a lot for gardening, instead of the shoe bending, you actually would be putting your foot on the ground. And so it does change a little bit, but again, most people that have this problem and it's bad enough, they don't have very much motion anyways, and they've already had to change some of the things they do because of it.
Thank you.
Any other questions? We also treat fractures. These are a little more obvious. I mean, you're not going to break your ankle and stay at home and try to treat it yourself. If it's swollen, bruised, and you did it doing something that you either shouldn't have or you just had an accident, come and see a physician so you can get x-rayed and taken care of. There are more subtle fractures though, like a stress fracture. You can see in this second metatarsal that can happen when somebody starts a new exercise program. And all of a sudden they develop pain and swelling, especially on the top of the foot. That's the most common area. And they're like, yeah, I didn't hurt it. And then they come in and we'll x-ray it, and they'll have this callus around it, is what we call it. So the body starts to try to heal that fracture. Again, if your foot's swollen, you should really come and see somebody. Because if this is left untreated, it can go on to a full-blown fracture where it breaks through and the bone gets out of alignment and may require surgery. But if it's treated appropriately, these never require surgery. They heal up on their own. I shouldn't say never. Most all the time. Ingrown toenails. So this goes back to my early days on the bed in my dad's room, getting my ingrown toenail fixed. And this is the way you're supposed to do it to fix it. Although my dad might argue with me on that point. So an ounce of prevention is worth a pound of cure. So first things first is try to trim the nails straight across. This won't prevent all ingrown toenails, but it'll prevent a lot of them, especially in the youth. So don't trim the toenails back in the corners. If you've already been doing that and been doing it for years, keep doing what you're doing, because the skin next to the toenail actually gets accommodated, or it gets used to not having the nail there. And if you have been that way for years, trimming your nails back, and then you start to let it try to grow out, then it may cause an ingrown toenail. So I don't want you to be cursing my name because I told you to trim your nails straight across. If you've been doing it for years, keep doing it. But ideally, we let them grow past the edge of the skin. That keeps it from getting ingrown typically. Although sometimes I'll have patients come in and they have this nail that curves all the way, and the nail actually curves in their skin in the middle, and it touches, and you just can't prevent. I mean, that's going to cause pain. We can treat that, and the way we treat that is permanent nail surgery. We can actually remove the sides of the nails permanently so that they don't grow back, and the toenail looks fairly normal still. So if you can imagine this toe with both sides gone, you'd still have a nail plate in the middle. A normal nail would grow in the middle, but it removes the borders that get ingrown. It's a great procedure. Takes 2 or 3 weeks to heal from, but most patients are very satisfied. So sometimes I'll have a patient that has really bad toenail fungus, and all the toenails are affected. They're very thick. They've failed all the treatments possible, and I will sometimes remove all 10 toenails permanently. And as you know, you say, "Oh, that's terrible." It looks a lot better than those toenails did beforehand. So it's something that is an option. It sounds drastic, and it's not for everybody, but we do sometimes remove the entire toenail. But for ingrown toenails, when it's just the border, we can remove the side permanently. You know, patients come in, we get that done all the same day. Don't have to reschedule or anything typically. The injection is the only part that hurts to numb the toe up. And we do a good job with that. We use a cold spray. If you ask somebody if they've had it done in 2 places, we do these all day long, and we're better than most people. Capsulitis. So this is, and actually we'll cover 2 conditions here, neuroma and capsulitis. If you've ever had the bunched up sock feel under your foot, but your sock is not bunched up, then it's likely one of these 2 conditions that was causing your pain or symptoms. So, capsulitis. The second metatarsal, you can see this is the second metatarsal. It's longer than all the rest. And because it's longer than all the rest, every time you step and you walk and your toes bend, then that joint gets a little bit more stress than any of the others. Because of that, sometimes the ligaments that support that toe and hold it in position can actually tear. And if they tear, that toe will go to the side. Once that happens, you're toast, unfortunately. Or your toe's toast, not you, but the toe won't ever go back straight. You can sometimes, with stiff-soled shoes again, so that toe doesn't have to bend so much, will sometimes alleviate some of the symptoms. But this one's a severe case. Usually they're not this bad. But you see that second toe? She doesn't have much of a bunion, so it wasn't the bully this time. But that toe became inflamed, and some of the ligaments tore, and it's stuck in that position. So you accommodate it or you fix it. So part of the problem, so basically the treatment for that is, again, accommodate it or you fix it. There are straps and things, and I'll show you in the next slide a couple of other treatments. So it's either capsulitis, again, so bunched up sock fill, or sometimes a stone bruise is what people describe it as under the ball of the foot. Capsulitis or neuroma. The difference between the 2 is a neuroma typically involves this area right here, between the 3rd and the 4th toe, and it has to do with the anatomy. Our nerves actually branch out as they go from your spine to your fingers or your toes. Well, there's one nerve in the foot that branches out, and I don't know why God created us this way, but it is this way. Probably so that we could all, there are many reasons. But anyways, but the nerve branches out, and then it actually reconnects, which most nerves don't reconnect with another nerve. So it reconnects in between this 3rd and 4th toe, and so sometimes that nerve is a little larger than it should be, and you can get a neuroma, which causes tingling sensations into the 3rd and 4th toes. High heels, again, cause this problem. So another reason not to wear high heels. But I see it in guys too, which most of them aren't wearing high heels. So stiff-soled shoes. There's these nifty little straps. They're called a Boudin splint. I don't know where that came from. But they can actually pull the toe down and hold it in a straighter position. Feels good, won't fix the ligament, but it feels better for a lot of patients. And then there's orthotics. There's a device where we can actually build up the inner part of the arch support, and it takes pressure off the ball of the foot. It feels a little awkward initially because you're walking on a lump, but it can take pressure off of the painful area, and then you get used to it, and it's great. So the treatment, if the other treatments fail, we can repair the ligaments surgically, and we can actually shorten the metatarsal. We do a bone cut that's actually parallel to the weight-bearing surface, and we shift that bone back, put a couple of screws in. It works really well. The only problem that some patients have is that toe loses the power to touch the ground. So it can be kind of aggravating, but usually the pain is much improved. So going back to what we talked about in the beginning is, we talked about a lot of conditions. If you don't have those conditions, you're probably going to forget about it after you leave here today. But what I want you to remember is appropriate shoe gear for your foot type or what you're wanting to do, making sure you have enough room in the toe box, making sure your shoes are in good condition. And those are really the most important things that you can do as patients or people to take care of your feet, and then taking care of the skin of your feet as well. And if you have a foot problem, don't ignore it. It's okay to self-treat for a little bit, but come and see a physician if you need it. Yes?
Could you comment on neuropathy and do you treat that?
So that's a good question. Neuropathy, do I treat it? I see patients with it, and I will start treatment for it, but I have it go back to the primary care doctor in the end. And the reason why is because neuropathy, which is usually numbness, tingling, and burning in the toes, and the reason I didn't talk about it is because diabetes and neuropathy are a talk all in and of themselves. So we'll talk about it briefly, but it could be a whole hour-long discussion by itself. We can't cure the nerves. Once they're damaged, they're unfortunately damaged, and so I will sometimes start treatment, whether it's vitamin supplements or gabapentin or Lyrica or something like that. But then I want you to go back to your primary care doctor, because you should have too many chefs in the kitchen or too many cooks in the kitchen. You want somebody that's managing most of your long-term medications, and that shouldn't be your foot and ankle specialist. Yes. Once you have drop foot, typically you can't. So nerves are tough, because once they are gone, they're typically a nerve can get damaged and it can regrow, but if it's been 6 months or a year and it hasn't come back, then typically it won't come back. And so the drop foot, which is basically a nerve problem where there's weakness in the foot and you can't lift the foot as you walk, that typically doesn't go away, and bracing is typically the best thing. There are tendon transfers, but it depends on the type of patient. Usually,
Can it get worse the older I get?
the drop foot itself, the weakness doesn't get worse, but the deformities in the foot get worse, and it's because of the tendons that are uninvolved. They keep pulling on the foot, and the tendon that is weakened doesn't, and so they overpower the other parts of the foot. Yes. For the pulse in your foot, let me go back to, if this foot had skin and blood vessels, you feel for your pulse. Can you see that? You feel for your pulse right along here, and then there's another pulse right behind so between the inner bone and the back of the bone of your foot. So there's one pulse back there, and there's one on the top of the foot. But really, it's hard to find, and you really should, if you're worried about your circulation, if you have cramping in your legs or your feet, or your wounds aren't healing like they should, then you need to see a doctor about that, because that's a pretty serious issue. So we talked about that. So this is where I practice. I have cards, I think, on a back table that you can pick up on the way out. This is my family, and we've got one on the way now. So this is a little older picture. So that'll be number 6 for us. We're excited. And any other questions? Yes. Not typically. It can. The fungus can cause changes in the shape of the nail, and it can lead to an ingrown toenail. But most ingrown toenails...
Only a result of an ingrown toenail. That's not the only cause of an ingrown toenail.
No. No, most ingrown toenails, probably 75% are from the ages of 10 to 30, and then the rest of them are in older patients.
Just good foot hygiene, I don't see much to do about keeping the fungus out from under the toenail.
Once the fungus, we have natural barriers to fungus, and they really think actually that some people have antifungal properties to the cells of their skin, and so they don't get nail fungus no matter what. And some of us don't have those natural protective properties, so there may not be a whole lot you can do. You want to make sure if you have an athlete's foot infection or a fungal infection of the skin, you want to make sure you treat that, because that can invade the toenails. But once a toenail infection has started with fungus, they have some decent topicals that are working better than they used to, or you take an oral medication for 3 months or more. I think we have a question here, and then a lady in the back.
What about creams for your feet that's supposed to be soothing, like creams for arthritis or creams for the neuropathy? Are they mentally correcting, or is it soothing? Is it work? Does it work?
That's a good question. They don't typically correct, but they can be soothing and they can be beneficial. With neuropathy, they've done a few studies on treatment of neuropathy with oral medications like gabapentin along with topical medications, and they can work better together. But you have to apply the topicals about 4 times a day, so it becomes difficult for patients to really comply with that, and oftentimes they revert to just the oral medication because it's taking your shoes and socks off and putting a cream on your feet 4 times a day is kind of difficult, especially if the medication is the most common one used, where you need to use gloves because it has chili pepper in it, and if you don't use gloves, you'll use gloves the next time. In the back. Wait 1 second, sir. Sorry, there's a lady just behind you.
The socks. What do you think is best for blends in socks? Cotton, nylon, what combination?
Good question. Polyester doesn't seem to absorb moisture the same, and so I prefer a cotton or a wool type sock, because they will let the moisture get away from the foot better. Fungus is the most common cause. As we age, they do get thicker and more brittle naturally, but if you notice that there's gross discoloration of the toenails, or you start to have some debris underneath the toenail, that is usually from fungus. Yes, here and then over there. Repeat the question. So cutting a V, so that you have a toenail, and in the front edge of the toenail you cut a V. They use a little V. It probably doesn't do anything, just from what I know of the nail plate anatomy. Over here. I prefer one called Power Step, but Superfeet are a good one. Superfeet are a little stiff on the surface, but they are a good arch support. I don't like Dr. Scholl's because I think you're wasting your money, because and I apologize if you got Dr. Scholl's and they work great. But for support for the foot, I don't think Dr. Scholl's are appropriate. For cushioning for the foot, Dr. Scholl's are just fine. But Superfeet are a good support.
What was the other one you mentioned?
Power Step. We don't have them in the Tri-Cities. You can find them on Amazon, though, online. That's a good question. It depends what you have, but I will often start patients on a non-custom device because most insurances don't cover custom orthotics. If everyone could wear custom orthotics, we'd all have happier feet probably. But an over-the-counter device is great for initial treatment, but if it's not taking care of your pain, then you need to come see me and we'll talk about customs, if necessary. I don't make them. I have a local orthotist make them, and they do a great job, but they're expensive. You're looking at about $400 to $450 if your insurance doesn't cover it. Some insurances do, but it's pretty rare. Yes, last question.
My husband has fungus on several of his toes. What's the best way to get rid of that? Topical
On the toenails,
Yeah.
if it's just the tip of the toenails, there are some topical medications that work pretty well if you have private insurance. If you don't, then it becomes expensive. But typically the most effective medication. So topicals, if it's only the tip of the toenails, up to 50% improvement after you use it 9 to 12 months. Yeah, I know, 9 to 12 months is a long time. Oral medication, it's called Lamisil or terbinafine. You take it for 3 months, and it's about 70% effective. So those are the two differences. The oral medication, though, does have some risks associated with the liver. It's pretty safe. We've used it for a long time now, and those have we're not as concerned, but it does have those risks. So. Okay, thank you.
So thank you so much for coming. I want to remind you that we do post all of our wellness programs on the website, and so Charter comes and records them for us. So we have that. Also, if you're interested and you want a copy of Dr. Freeman's slides, I am more than happy to mail them or email them to you. And then Dr. Freeman left some cards in the back on a chair. So thank you so much for coming, and we'll see you next month.